point is on inflammation. This will be module 3 for you, and we will be covering parts of immunity in this so that you can understand inflammation a little better. I will be posting 2 videos to kind of remind you guys about the patho of what happens with inflammation in the immune response. That way everything kind of ties together for you. Okay, so let's go to the next slide here. These are our objectives. What is inflammation and what are immune complex diseases? How to assess your patient for, treat, and educate your patients with these diseases. You need to know osteoarthritis, rheumatoid arthritis, fibromyalgia, and gout, and systemic lupus, erythm. I just call it SLE. I can never say that other word. I apologize. And then you guys want to make sure that you know the labs and tests to diagnose each of these problems. Okay. Autoimmune disorders. What is an autoimmune disorder? This is when you have inflammation that targets and destroys its own cells. Small antigens are going to bond with the healthy tissue, and the body is going to respond by creating antibodies that then attack the healthy tissue. Toxins, medications, bacteria, and viruses can all cause this reaction. And when you think of autoimmune, you need to think of the body attacking itself. It's the only way to really think about it. Autoimmune means that the inflammation, the healthy tissues or the antibodies are attacking our healthy tissues, okay? The goal for treatment of this type of disease is going to be to treat the symptoms. We cannot cure autoimmune disorders. But what we can do is we can decrease that inflammatory response by managing the problems that occur and then manage the problems that will occur with those symptoms, okay? All right, let's go to this next slide. This talks a little bit about inflammation. So clearly this gentleman has inflammation in his patient's right leg over there. The signs that you probably would feel and assess under inspection, you can see redness, you can see swelling. If you touched it, you would see warmth. If you ask the patient what his pain is on a PQRST scale, he's probably going to say, we're going to say this gentleman's going to say a 9 out of 10. That looks pretty painful. It looks really warm to me as well. If you asked him to move that leg, he's not going to be able to move it. So he's going to have decreased function, pain, swelling, redness, and warmth. Now I want you guys to understand that during these next 2 modules that we're covering, modules 3 and 4, we're talking about inflammation and immunity. We need to also make sure we remember how to assess for pain and manage pain in our patients, because all of these patients are going to have pain. And we need to go back to kind of 5th semester and remember PQRST. We need to remember that we need to know location, we need to know the quality, we need to know the intensity, and that's the 0 to 10 scale. We need to know when it started, we need to know how the pain affects daily life. We need to know the associated manifestations and the aggravating relieving factors. And you guys need to understand what types of questions you would ask your patient if they came in with pain. So chapter 4 in your purple RN Adult Medical Surgical Nursing book in ATI has like 3 pages on this. Just review those content pieces and start applying them to the patients we're going to be talking about. So how do you know your patient has inflammation? We just talked about it. Our 5 cardinal signs: warmth, redness, swelling, pain, and decreased function. Those are your cardinal signs. I just answered them. So for each sign, what are the findings? So we're looking for, do you understand where the warmth, redness, and swelling is coming from? And we have to remember that when our patient gets a stimulus, whether it's a pathogen, an injured body cell, or trauma, first thing that's going to happen is we're going to have those inflammatory mediators come out, like our cytokines, and they are going to dilate our blood vessels, which is going to lead to the redness, heat, and the swelling. Then you guys are going to have your plasma fluid take place. It's going to kind of do its next thing, and the plasma fluid is going to have your blood clotting factors, your antibodies, and your platelets, and that's going to stop the bleeding or kill the pathogens. In my immune PowerPoint, you will see a beautiful picture of a needle poking the skin, and I will go through this whole entire process with you. But just remember that we have different steps in this cascade. Once the body is stimulated by a pathogen, the injured body cell, or trauma, certain steps are going to take place, and that is the inflammation or the inflammatory response. Okay. All right, let's go to the next page. Now we're going to talk about osteoarthritis. Now, you guys are going to have to be able to answer these questions about each of the diseases that we cover. And I just wanted to put the questions out there to see what you guys could find in your ATI. In osteoarthritis, what is the disease process? Okay, what is happening with this disease? And what's happening is it is a degenerative joint disorder. Okay, the joint, you use the joint too much, it's going to start breaking down that joint, and it's going to cause the cartilage and bone beneath to erode, which can also cause bone spurs to form, which is going to narrow the space in the joint. So you see in this picture here, it says evolution of osteoarthritis. You see where we have normal bone cartilage starting to thin here, thinning of cartilage right here. This is what's happening. Think of this person as someone who works at a manufacturing warehouse, and they're constantly using their elbows, and they're bending them, and they're setting something down, they're picking something up, they're bending them, and they're setting it down. That joint in that elbow is consistently being used, and it's going to start breaking down that joint, okay? This patient is going to have a lot of problems when this occurs, right? If you look at this picture right here, you see this bone, you see this tiny little bone spurs? Imagine moving your elbow and having little tiny bone spurs in there. That's not what you want, that's not what you want to feel when you bend that joint, okay? So who's at risk for getting this disease? Well, I have this lady over here. She's a great illustration for you, okay? Obese, excessive use, and female. So if she's a marathon runner, she is not at the correct BMI, right? She's at an obese BMI, we'll say, over 29.9. She has weight-bearing stress on her knees and hips if she does this all of the time, and she is using her joints excessively. So if she's a marathon runner and she runs marathons, we'll say 5 days a week, well, that's crazy. Okay, how about 5 days a month, right? She does once a week, she runs a marathon. She's crazy about it. This combination of obesity, being female, being excessive use of her joints, and then also increased over age of 60, which I could not find a little old lady that was a marathon runner. So those are risk factors for this disease. Let's look at expected findings. So what are you going to assess in a patient with this disease? What are your expected findings? So we already know there's going to be pain, but you're going to feel pain with palpation or movement. So if this lady has osteoarthritis and she's a marathon runner, every time she goes to run, we'll say she has it in her knees, it's going to be very uncomfortable, and it's going to decrease her function with that joint. So she's not going to be able to run marathons as well anymore. Okay. They are going to be non-symmetrical. So you're going to have one joint that is going to be enlarged, not both joints. Okay, this is not a systemic disease. This is oops, 1 second. Okay, sorry about that, you guys. I hit the wrong button. I can't go back to the other slide, so please go back and look at the question slide. We're still on that slide, but I want you guys to see that this is not just wear and tear with aging. This is because they use this joint too much. They can have crepitus, which is the palpable or audible grating or crunching sensation produced by motion. So I put those little Rice Krispies in that picture on your previous slide to help you with that. When you bend the joint, the air bubbles burst and you hear a cracking sound. They're not going to have symmetrical and large, non-symmetrical and large joints, okay? So one joint at a time is going to be enlarged. They get what's called Herbert's nodes at the interphalangeal joints. They're going to have pain with palpation or range of motion, and loss of function. they can have muscle atrophy, and they're going to have maybe a limp when walking. Some labs that are going to increase are going to be your ESR, your erythrocyte sedimentation rate, you're going to have a high C-reactive protein in the later stages when the synovial fluid becomes inflamed. Tests that they can do, X-ray joint changes. They're going to see that there's a change in the joint. If this is how it's supposed to be, this is normal, if you look here at grade 1, and this is what they see at grade 4, there's clearly a change there, and they will be able to see that, okay? CT, MRI, then they'll look at the knee joint and the vertebrae, and they'll be able to tell. Let's go to your next page. So I want you guys to understand that it's kind of difficult to distinguish between OA and RA in their first stages. So make sure you really look at the differences between what OA symptoms are and what RA symptoms are, because there are some differences, and I'm going to try to point those out to you guys in this PowerPoint. So what does the nurse do? Let's go to the next slide here. What does the nurse do? If your patient has osteoarthritis, what does the nurse need to do for this patient? So we need to do pharmacological and non-pharmacological pain relief. Remember when I talked about pain, we have alternative methods of pain and we have pharmacological methods of pain. Tylenol is a great one, but we also have to remember that you can't have more than 3,000 milligrams in 24 hours. So if the Tylenol's just not cutting it, we can try lidocaine patches. We can try salicylate patches, which is like an aspirin. They have gels, patches, and creams for that. NSAIDs, these are okay, but remember, we don't want them to overuse any of these medications. If the pain is bad enough, these patients will get prescribed opioids. They can also get muscle relaxants like cyclobenzaprine, okay? Other things that can help to strengthen cartilage and reduce inflammation would be glucosamine and chondroitin. If you have dogs, you probably know that they want you to put your dogs on that right away, because that's going to help to reduce inflammation and strengthen their cartilage so that they can support their bodies throughout their life. Obviously the doctor is going to have to prescribe these drugs for your patient, but you guys are the ones that are going to have to guide your patient in using them when it's appropriate. So what are your priority concerns for this patient? What is the number one thing that this patient needs from you? Take a second to think about it. We need to decrease the degeneration, protect those joints so that they can increase their activity, okay? So cold therapy is going to help reduce inflammation. The nurses can do this, right? Heat can help for joint tenderness and muscle stiffness. Hot baths and showers are good. We can get a prescription for exercise regimen. They need to do it consistently. Active exercises are better. So walking is a fantastic exercise for someone that has osteoarthritis. It's not going to be too hard on the joints, but it's going to help them to keep using them. Surgery is going to be an option for this patient. Total joint replacement, so an arthroplasty. And you can see here, this is where the joint is, this is the replacement. You guys have probably heard of these. It's not a difficult procedure. They do these a lot in patients. That's it for osteoarthritis. So I want you guys to remember, you need to know how to assess for osteoarthritis. I need you to be able to determine who's at risk for osteoarthritis. You need to be able to tell me what the disease is. So what's the pathophysiology of it? What are my expected findings? Once again, enlarged joints are going to be one at a time. So one side over the other, not right and left, but just right or just left, only one joint at a time. You're going to have something called Herbert's nodes at the interphalangeal joints. They're going to have pain with palpation or range of motion. So even though it's going to hurt them to walk, this is still the best choice for this patient. All right, let's move on to rheumatoid arthritis. Now, remember, I said rheumatoid arthritis and OA are difficult to distinguish in the earlier stages. So let's look at, first off, what is rheumatoid arthritis? What does what is this patho? And the patho is where the synovial membrane gets inflamed. So the synovial membrane is the synovial fluid is what they're talking about, okay? So when that becomes inflamed, there's going to be cartilage destruction, bones are become eroded, there's going to be an inflammatory response. It's autoimmune, right? So this is where the inflammation is causing, the inflammation is attacking the body and is not helping the body anymore. This is going to happen to all of the joints. So this is systemic. This is both left and right, okay? This is not just one limb over the other. They're going to have swelling, redness, pain at rest. They're going to be underweight, and it is going to be symmetrical, all right? Have to understand that rheumatoid arthritis can affect more than just your mobile joints, like your knees and your fingers and your elbows, like you can with OA. We have the upper joints usually are affected first in rheumatoid arthritis. You can see these pictures. Here's early rheumatoid, here's intermediate rheumatoid, and here's your late rheumatoid. This is the swan neck or boutonniere and boutonniere deformities that you will see with rheumatoid arthritis, okay? After it affects those upper joints, it can affect other connective tissue blood vessels. So pleura around the lungs and the heart and the eye vessels. This is not just a joints in your mobile, in your legs and arms and hands like we seem to think, okay? This can happen in multiple places. So remember, heart, eye vessels, and lungs, all of the pleura, the tissue, the connective tissue blood vessels around the pleura can be inflamed and affected. Patients that are at risk for getting this disease are your females, if they have genetics for it, stress and smoking. You see our little old lady over here smoking her cigarette, older age, and environmental factors. Okay. Upon assessment of this patient, they could be complaining of pain at rest or after being immobile for a while. So if they've been asleep and they wake up and they have pain, that's considered morning stiffness. That's a great indicator of rheumatoid arthritis. They will be underweight. They will have swan neck and boutonniere deformities. They will have systemic lungs, heart, skin, and extra articular pain with inspiration, dry mouth, and jaw clicking with eating. These are all signs of rheumatoid arthritis. Now remember, some of these might seem similar to OA. Remember, if you know that RA and OA have the same signs like swelling, redness, and warmth, you can just remember that and then go to the things that set them apart. Go to the things that set them apart. Jaw clicking with eating, swan neck and boutonniere deformities, pain at rest, and it can be a systemic inflammation of the lungs, heart, and eye vessels. Okay. So let's look at what labs will be done and what will be the expected findings. So with rheumatoid arthritis, there's going to be an increase in your ESR, your CRP, and they're going to be positive for the rheumatoid factor. An ANA titer will be done, and a white blood cell increase can occur. Tests that can be done, the only real test that they can do is they can do an arthrocentesis where they do a needle aspiration of that synovial fluid to test the synovial fluid. And the x-ray can determine the amount of joint destruction. So here you can see there's a bunch of pictures, but hopefully kind of help tie everything together. This is just one of those nice pictographs if you guys like those or not, but here's one for people who do. Here you can see what it looks like when, let's see, this is where we have an excessive amount of cartilage loss, and we have, this is what happens with when we run out of the synovial, your synovial fluid. And okay, let's move on. Sorry, guys. Okay, let's do this. What do nurses do? All right, so We need to monitor our patients for pain. Okay, we need to monitor our patients for pain. How will we treat the patient's pain? Well, we have some medications, we know that, right? So some meds that the doctor will prescribe are COX-2 inhibitors like your celecoxib, your NSAIDs, some steroids to decrease inflammation, so corticosteroids. You have MARDs, which will slow the progression of RA by suppressing immune system's reaction to the RA. Remember in class when I said earlier that the only way to really slow this down or decrease these symptoms is to stop the immune's response to them, because it is the immune it is the immune response that is causing the problem. So if we don't have an immune response, or we decrease the immune response, we can lower the side effects. So anti-malarial medications like hydroxychloroquine, you can take sulfonamides, cytotoxic medications like methotrexate, and antibiotics are all given for these patients. Now, when do we give antibiotics, you guys? That's right, when we have an infection. So do you think it's possible that that synovial fluid could potentially become infected? Yes, it can. So if your patient, let's say their RA is in their interphalangeal joints, and your patient comes in complaining of a lot more pain than usual in that right hand or left hand, let's say it's in the left hand, okay? They're complaining of a lot of pain. Is this a priority concern to you? They say, oh, the pain's so much worse than usual. And the answer is yes. Upon assessment, you see more swelling. The swelling's moved to the wrist. It's hot and it's red. What should you be thinking? Correct, that there is a possible infection. So this patient, after we check that those white blood cells are increased and that the patient does have an infection, we are going to get them on some antibiotics to stop that. This is an emergency because this is in the synovial fluid, and and this is systemic, right? So we need to make sure that we take care of this fast. We need to educate our patient to conserve energy. This is the whole patient, right? Is this patient going to be tired if they're in pain all the time and they have swelling in their joints, multiple joints, because this is systemic? The answer is yes. But do we want our patients to sleep all the time? No. Bed rest is going to cause pain to these patients because immobility causes pain to patients with rheumatoid arthritis. Okay? They're going to become very, very stiff. How do we teach them to conserve energy? We're going to ask them to space out activities, take rest periods, ask for additional help when needed. So maybe someone can help clean the room, help clean the house, things like that. They don't need to be doing everything all at once. They need to be smart about conserving their energy. Hot shower for morning stiffness is fantastic for these patients. If they're stiff, that warmth is going to help open up those blood vessels, get more blood to those to that area, help decrease that stiffness. If they have swelling, we can put cold on it, but we want to make sure we're using those appropriately, right, per the doctor's orders. So let's see what else we have here. If the patients if we're teaching the patients to monitor for infection, conserve their energy, understand that they need to move around a little bit and they need to do it progressively. They don't have to do it so crazy. Go to the post box, go walk to the post box or take your dog for a small walk, then come home. You can sit down for a little bit, but we do not want them sleeping or laying down and not moving because this will make them stiff. Who's going to be on this interprofessional team? So let's see, physical therapy, right? Home health aid, support groups. Support groups will be great. It's going to change this person's life if they find out that they have RA. And remember, these autoimmune disorders cannot be cured, so that's going to be something that they're going to have to manage. Let's think about some patient education for some of the medications that we'll be giving our patients. So patient education for your antimalarials, or let's say like hydroxychloroquine. If your patient's on hydroxychloroquine, There's a major side effect of using this medication where we need to make sure that our patients are getting eye exams every 6 months, okay? Methotrexate is going to decrease their bone marrow production, decrease their white blood cells, and it is not okay for pregnant mamas, okay? So pregnant ladies cannot be on methotrexate, and that is one of the MARD medications that I was talking about. So remember, it's not just education about the disease. We have to educate them about the interventions and the things that we're going to do to help these patients. Okay, let's move on to fibromyalgia, I think. There we go. Okay, so fibromyalgia is one of those diseases that we have to make sure that we treat it as a disease. And when I say this, it is a chronic pain syndrome due to the brain and spinal cord perceiving pain signals. So these pain signals are going to be amplified in patients that have fibromyalgia. Doesn't necessarily mean that they don't have pain, and it doesn't necessarily mean that they do have pain. So we have to remember that we have to treat it like it's real. You may not be able to see anything nothing indicates that they have fibromyalgia. So if we go to labs and tests, there's not a test to indicate that someone has this. We can watch for an increase in that ESR and CRP, which are inflammatory markers, right? We can watch for an increase of those things, but there is not a defining test that indicates that they have fibromyalgia. So this is one of those diseases that the doctors are generally going to assess the patients for their expected findings or the signs and symptoms. And if the patients say these specific things, then they will most likely diagnose them with fibromyalgia. So some of those expected findings, they can have a whole bunch, but some of the main ones that we're looking at are like tender points of pain, so like in their knees, their spine, and their back, severe fatigue, sleep disturbances, chronic fatigue, so they're always tired. They can have jaw pain, GU problems, exacerbations from stress, activity, and weather. A lot of things can trigger this for patients. This can mimic a lot of other diseases. If you look at some of these signs and symptoms, I mean, we've got muscle weakness, GI problems, depression, memory problems, headaches, gnawing pain at the trigger points, chest pain. If you look at all of these signs and symptoms, it can mimic type 2 diabetes, thyroid disease, MS, lupus, anemia. There's so many different diseases that this mimics. So we really have to be careful when the doctors diagnose a patient with this, that we make sure, that it's not a different disease that's showing these. So we would definitely look at those labs and diagnostics, because there's going to be defining diagnostic tests for those diseases. And generally 25 to 65% of people with fibromyalgia are going to have a different, another rheumatological issue, like rheumatoid arthritis or lupus. Our risk factors. So who's at risk for these things? Females, 30 to 50 years of age, history of rheumatologic conditions. So do you already have RA or SLE? It's possible you could have fibromyalgia too. Chronic fatigue. So people who are already tired all of the time could end up with this. Lyme disease, a different trauma. So if you have a major trauma in your life, this could trigger fibromyalgia. You put you at risk for it. And if you have flu-like illnesses, can trigger you for fibromyalgia. So there's a lot of things that put people at risk for this. Let's take a look at my picture here. So what do nurses do for our patients with fibromyalgia? And the answer is pharmacological treatment, okay? But let's think about this for a second. If this patient is having all of this pain and all of these different symptoms, what types of drugs do you think we need to put them on? Remember, I said it was the brain's brain and spinal cords perceiving the pain signals more amplified than maybe in a general person. So we want to look at antidepressants and anti-seizure medications like your duloxetine and fluoxetine. So We're looking at antidepressants. Here's your duloxetine or Cymbalta, okay? Anti-seizure medication or anticonvulsants like pregabalin right here. You can see those two are great. NSAIDs are perfect for these patients, help decrease some of that inflammation. We can give muscle relaxants like the cyclobenzaprine. Here's another antidepressant. Here's another antidepressant. You guys just understand antidepressants as a whole. It's huge for these patients. Let's see. Do not give opioids for these patients. If their pain never goes away, if this pain is consistent and chronic and causes them to be tired all of the time, opioids are going to be extremely habit forming for these patients. And they aren't going to help this type of pain because remember, it's the brain and the spinal cord amplifying pain that may or may not be there. So we need to treat the nerve receptors with our anti-seizure medications and the muscle relaxants to help to hopefully decrease the pain. These patients are not generally happy people because they have this pain all of the time and it decreases do the activities that they enjoy. So we need to make sure that if they need antidepressants that we put them on it and we explain to them why they're on them too. So non-pharmacological interventions is we need to teach the patient to positively think. So cognitive behavioral therapy is a fantastic way to help these patients. Aerobic exercise, getting them moving around, thinking about other things. Physical therapy is going to help them to maintain their strength and function. And we need to educate them on this disease. We need to educate them and tell them, yes, we know you have this problem. This is your disease. We need to acknowledge that that's the thing, but we need to help them to overcome it. We need to help them to understand that get a good night's sleep, pace your activities to help improve your energy using occupational therapy, physical therapy, and counseling, like cognitive behavioral therapy. Using those anti-seizure drugs, antidepressants, and NSAIDs appropriately. Exercise, like aerobic exercise. Get your mind focused on something else. There's a lot of different ways that we can help these patients in a non-pharmacological way. So, visual for you guys, it's pretty nice. Just to remember, these are some of the alternative complementary treatments or alternative treatments for these patients. These are always options, and we need to make sure our patients are aware that if they want to try these, they should. It's very possible that it could help them. All right, now we're on lupus. Systemic lupus erythematosus, okay? Another autoimmune disorder. It has an atypical response, so which means this is not a normal response. So chronic inflammation and destruction of healthy tissues occurs. Has flare-ups and remissions. So this is one of those where someone could say, I'm having a flare-up of this, or they can say, you know, oh, my lupus has been in remission for X amount of time. There are three types. There's systemic, so those are your connective tissues of multiple organs. Discoid, which is just the skin, or you can actually have medication-induced lupus. For testing purposes and just general purposes, we're going to focus on systemic lupus erythematosus. So these patients, even with proper treatment, can still have an unpredictable course. So once again, this is an inflammatory autoimmune problem. This is the body attacking itself. And so if your inflammation response is strong, it's very possible that we won't know what's going to happen to that patient until it actually happens. So generally we can kind of predict where a disease is going to go based on what we give them and what we do with them. This one is very unpredictable. So it's a little sad for these patients because sometimes no matter what we do, we still don't know if it's actually going to help or not. Some expected findings for these patients. You guys have probably heard of the butterfly rash on the face. You can see it in this picture right here. Okay. It looks very different depending upon your patient, but in general, it looks like a butterfly rash. It's also called a malar rash, all right? Patients can have fatigue, malaise, alopecia, blurred vision, pleuritic chest pain, anorexia, depression, joint pain, swelling and tenderness, anemia, pericarditis, so pleural or cardiac friction rub can occur, Raynaud's phenomenon, so that's when we have a vasospasm to cold or stress. Fever is a huge indicator of an exacerbation of SLE. Your patients, this is very, very difficult to diagnose due to the vague onset of symptoms. If your patients come in and say, oh, I have some joint pain, fatigue, and malaise, you're not going to just jump on lupus. You're going to have to go through some stuff. So if we're looking at our labs, we have the ANA, which is the anti-nuclear antibodies. These are the antibodies that are produced against one's own DNA. So if the titers are positive in 95% in lupus patients. So that ANA titer is going to be a huge indicator that our patient has lupus. Your creatinine, your BUN, and a UA are going to help you to understand if the kidneys have been involved. Now, this is huge for our lupus patients because, as you can see, we have heart problems, we have lung problems, we can have eye problems, blood problems, joint problems, but the biggest problem that has killed the majority of our lupus patients is lupus nephritis. And lupus nephritis, you're going to see periorbital edema, swelling, hypertension, and a high BUN and creatinine. This is an emergency if you're doing an assessment on a lupus patient. Okay, this is the leading cause of death for our lupus patients. Let's look at who's at risk. So risk factors for lupus: ages 20 to 40. Asian, Hispanic, or Native American, environmental or genetic factors. Both male and female patients are at risk for this, but it will decline in our females after menopause. Okay. So remember some of your signs and symptoms: the malar rash, fatigue, malaise, alopecia, swelling and tenderness, pericarditis. How do you know your patient has a pericarditis or inflammation of the heart? They're going to have chest pain, fatigue, changes in their rhythms or arrhythmias, and a fever. Okay, let's look at one of those pictures I was talking about. This is really nice, shows you a nice little breakdown of everything that I've talked about. Proteinuria and hematuria are two other signs that you will see if your patient has lupus nephritis. So you make sure that if you assess those things that you notified the doctor right away. So what do nurses do? You guys have noticed now that there are pharmacological and non-pharmacological methods, and we need to make sure that we understand that both can help our patients. So what do we need to look for if our patient comes in with lupus exacerbation? We need to ask our patients about nutrition. What kind of nutrition does our patient need? So are these patients going to be tired? Yes, we said fatigue, we said malaise. And they can have chronic pain too, right? So we need to make sure that they take small, frequent meals and between meal supplements. And you guys know how I like to do these silly things. So here's a good meal, and then we have our protein supplement. And then here's another good meal, and then we have our protein supplement. And then here's another good meal, and then we have our protein supplement. So you can see I tried to support your, visual on that. We want to make sure that they limit their salt intake and drink enough water. These patients are going to be on corticosteroids, and they're going to have too much fluid retention secondary to those steroids if they're taking in too much salt. So we need to just make sure that they have a healthy amount of salt and that they are not overdoing it with the salt. We want to give them emotional support. Okay, this is going to be a heart disease for them to work through. So we need to give family and the patient support. We need to make sure that they follow the rules of their medications. And you can see here, these are the MARDs, right? We have methotrexate again, and we have hydroxychloroquine. If our patients are on these, our antimalarials and our MARDs, we have an immunosuppressant of methotrexate, which is a MARD drug. We need to make sure that our patients understand that they need to limit their sun, okay, or protect themselves when they're in the sun, decrease sun exposure. We need to make sure that they avoid crowds when they're on the immunosuppressant because their immune system has been suppressed, meaning that it can't fight normal things like a cold or a cough or whatever it may be. We need to teach them that they cannot get pregnant while they are on methotrexate. So they need to understand pregnancy in relation to their treatment medications. So you can see I have pictures here. Sun, don't be in crowds, and then don't get pregnant. This is a bad idea if you are on a MARD. You will have problems with your baby. It is a teratogenic, so it will kill the child inside of you. We need to make sure that our patients understand they can take NSAIDs, they can do corticosteroids to help decrease this inflammatory response, the immunosuppressants are going to help, and these antimalarials are going to help. And with hydroxychloroquine, we talked already, retinal toxicity is a huge major side effect of this medication, so our patients need to get an eye exam every 6 months to ensure that they're not getting retinal toxicity from this medication. All right, this is, guys, you hung in there this whole time. Gout. You guys have heard of this, I'm sure. It is an extremely painful disease. If your patients have gout, they are going to have pain 10 out of 10, and it is going to be extremely comfortable. Now, if you go to your next page on here, it kind of shows what is gout and symptoms of gout. Think about it. If you have uric acid, think of them as uric acid crystals in that big toe. You see where that big red bulb is here? This is where all the swelling is. If you curl your toes, it's like you have glass in your foot, okay? This is very uncomfortable disease. So what it is the most common inflammatory arthritis that we have, okay? It's a systemic issue due to improper purine metabolism, where our monosodium urate crystals are deposited in joints and body tissues. Generally, our kidneys take care of these things. And with patients that have gout, that's not what happens. You're expected finding severe joint pain in your metatarsophalangeal joint of the great toe, redness, swelling, and warmth, okay? Big inflammation marker, right? ESR is going to be elevated because we know that's a huge inflammatory marker. Their uric acid serum is going to be above 6.5 and their BUN is going to be elevated. So if you see these things in this patient, then you're going to know they have gout. Something that they can do to ensure that it's gout and not something else is they can aspirate the synovial fluid and analyze the uric acid crystals in the affected joint. But to do that, they have to stab this big red bulb here that I was referring to with a giant needle and withdraw those uric acid crystals out of there and test it. So most people don't want to get stabbed with a giant needle. So we need to check their level, their serum level. And you can see I put that here, right here, serum level to determine if it is gout or not. Risk factors. This used to be called the rich man's disease. And you can see up here that we've got some nice looking beers and some nice, carcinogenic meats, some expensive meats there. It is a huge, it's called rich man's disease because these are the things that are going to have purine in them. So, which is like no organ meats and no shellfish. And you want to limit your alcohol intake. You want to make sure that we increase those fluids, okay? But your obese patients, postmenopausal patients, patients that use diuretics, people who drink a lot of alcohol, have cardiac disease, trauma, chronic kidney failure, because the kidneys aren't going to be doing what they need, right, to remove that uric acid. And this can also be hereditary. So If it's in the family, you are much higher risk for it. So let's look at this next talking about. So this kind of just describes what gout is, what causes the buildup of breakdown products of purines that are part of many foods that we eat. This is just the body's way of not being able to, it's not going to handle it correctly in the body. And so then it goes to your nice big toe here. You can see here it says, cause attacks of painful arthritis, kidney stones, and blockage of the kidney filtering tubules with uric acid crystals leading to kidney failure. So that's something else that we need to make sure that we assess in our patients, right? They have gout. What do we do? You can see here that it can happen in a finger too. And the big toe is the biggest one, the biggest location of where we usually find it. But maintaining adequate fluid intake and avoiding drinking alcohol and avoiding those because we want to increase our kidneys' ability to function, right? And fluids are very good to help your patients that have gout. So what are we going to do? Pain control. What kind of meds can we give these patients? We can give these guys opioids. They're going to have 10 out of 10 pain, and this isn't the kind of pain that lasts forever. Once we fix the problem, this is going to go away. We have anti-gout meds like allopurinol or colchicine. We can put them on corticosteroids to help decrease that inflammation, right? NSAIDs are fine, but we want to make sure that if this patient already has a kidney problem, that we are alert to that and we don't tell them to go on NSAIDs. So your aspirin and diuretics, you can see I have an X here on Lasix, which is a diuretic, and aspirin. These are going to alter or raise the blood levels of uric acid in your body. So that is why we do not want these patients that are at risk for it or have a history of it to take these drugs. The other one that we didn't talk about is starvation dieting. Okay, starvation dieting can trigger our gout attacks because it's going to increase your uric acid levels. During starvation, your kidneys and lactic acid, your ketones and lactic acid are going to increase, and that's going to impair the kidney's ability to eliminate the uric acid. So no to aspirin and diuretics. No to starvation dieting because they're obese, right, generally. So because those are the people that are at risk for it. We don't want them starvation dieting. We want them to make healthy choices. They need to not eat shellfish or organ meats or drink alcohol. And that is possible for them, right? We just have to help educate them on that. And then they also need to limit physical and emotional stress because that can trigger, that can also help to trigger their gout attacks. Woo! All right, guys, 47 minutes and 36 seconds. We did it! This is what we will be discussing next week. I'll let you guys know that the plan is I'm going to have you guys get into groups again, and I'm going to put posters up with these disease processes, and I'm going to have you guys just brain dump whatever you can think of, whatever you can remember. And then after that, we'll probably do some NCLEX questions as a group and see where we're at with the content. And then from there, we will start talking about immunity as a whole, and we'll get into that PowerPoint a little bit. So if you get through the inflammation one and you feel comfortable, go ahead and start on that immunity PowerPoint in Module 4. It's a lot of stuff that you guys have heard in 5th semester. The new stuff is going to be your like MRSA, C. diff, HIV. We're going to start touching on some of the disease processes that come with the immune system. So lots of bacterial infections, fungal infections, things like that. All right, guys, I hope you enjoyed this PowerPoint. I hope you took notes, and I will see you guys next week. Have a great day and good luck on your test.